Hey guys, today we're going to talk about neurological alterations. This is actually the first lecture of Module C. We'll talk about TIAs and CVAs. I'm sorry that I wasn't able to do this in class today. However, there were circumstances beyond my control that I was out. So we're going to Camtasia it and it'll be available for you. At the beginning of the lecture, of course, here are the objectives. These are actually state mandated. This is what the state passes down to us and says that we will cover while we're in the class. So I have these on the front of this PowerPoint for you. You can read through those. Just some interesting facts. CVAs is the most common cause of disability in this country. It's the third leading cause of death. CVAs are actually on a decline in the last 15 years. However, the younger population, there's an increase in their population, their age. And that's due to IV drug use, crack cocaine. It causes some clotting issues. It can also cause vasospasms and sudden increases in systolic blood pressure, causing the strokes. Another interesting fact that patients that have a stroke will usually have another stroke within a year. But these are just some of the facts about CVAs. So what is a stroke? A stroke is a disruption in the normal blood flow to the brain, and this can be caused one of two ways. It can either be an ischemic stroke or it can be a hemorrhagic stroke. One being that a clot has formed, or the other one being that there's bleeding in the brain, which is the hemorrhagic. Both are considered medical emergencies and should have treatment immediately. And we'll talk about time frames a little further as we move along through this and why time is so important for stroke patients. With a stroke, you can have a loss or impairment of function, and that can be anything from movement, sensation, emotions. But this is all based off of the severity of the stroke. So the more brain tissue that is involved in the stroke, the more severe the impairment or the loss of function will be. We're going to watch this video on some signs and symptoms.
Strokes are the third biggest killer in the United States today. Learning the warning signs of a stroke is crucial and could just save a life.
A stroke occurs when there's an interruption of blood flow to the brain. This causes the death of brain cells and results in brain damage. In America, 700,000 strokes occur annually. The symptoms of a stroke depend on the type of stroke and what area of the brain is affected. As early as 400 BC, the Greek philosopher Hippocrates described the stroke phenomena of sudden paralysis. He uses the term apoplexy from the Greek word meaning struck down with violence. Hippocrates had the right idea. One of the most common signs of a stroke is sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. People who are having a stroke can also experience trouble moving due to dizziness, loss of balance, or loss of coordination. Stroke victims may experience trouble speaking or understanding. Sudden confusion is also common. Other possible indicators of a stroke include sudden difficulty seeing and a sudden severe headache of unknown cause. Experiencing any of these symptoms may be an indication of a stroke. However, these signs can also point to a transient ischemic attack or a TIA. TIAs are mini strokes, being like a regular ischemic or blood clot stroke. A blood vessel to the brain becomes blocked or leaks, halting the flow of oxygen and nutrients. The difference between TIAs and full-blown strokes, however, is that TIAs are reversible through normal body repair mechanisms. Even though TIAs disappear on their own, they are an indicator that a major stroke could occur. It is important to receive immediate treatment for TIA because more than a third of people with this condition have a full-blown stroke soon after. If you think someone around you may be having a stroke, act FAST or fast and do this mini test. Face. Ask the person to smile and note if one side of their face droops. Arms. Ask the person to raise both arms and see if either arm drifts downward. Speech. Ask the person to repeat a sentence and listen carefully to the words. Are they slurred? Are they correct? Time. Any of these symptoms are a sign of stroke. Get the person to a hospital quickly. It's important to remember that both TIAs and strokes are emergencies. The longer that treatment is withheld, the more brain cells will die. Knowing the symptoms of stroke is a positive step you can take to avoid the severe damage or death that can result from the condition. Talk to your doctor if you have any concerns about stroke.
Want to learn more? Check out other videos and sources on this site for more information.
The United States has what they call a stroke belt, and of course that's here in the southeast, so we are part of the stroke belt. But some of the risk factors that are non-modifiable, basically meaning that we can't change our age, gender, race, and of course family history. An age greater than 65 puts us at a greater risk for a stroke. However, every decade over 55, your risk for a stroke doubles. Men are more likely than women to have a stroke, and when it comes to race, African Americans are more likely than whites and Hispanics to have a stroke, and this is due to diabetes, hypertension, obesity, and sickle cell. And of course, if you have a family history of strokes, then you're at an increased risk for strokes. And then we also have risk factors that we can change, or they're also known as modifiable risk factors. And these are hypertension, metabolic syndrome. Metabolic syndrome is an increase in triglycerides greater than 150, a decrease in HDL less than 40 to 50, an increase in blood pressure, and an increase in blood sugar greater than 100. So these together create metabolic syndrome, which is the increased triglycerides, the decreased HDL, the increased blood pressure, and the increased blood sugar all make up the metabolic syndrome. Other modifiable risk factors, alcohol consumption, diet, obesity, and smoking. On their drug abuse, the leading cause of drug abuse, the drug specific, is cocaine. And then with smoking, cigarette smoke actually doubles your risk for a stroke. So how do we receive blood flow to the brain? Well, blood supplied to the brain by two major pairs of arteries, the internal carotid arteries and the vertebral arteries. And as we kind of review some of these arteries here, make sure that you go back and you review cranial nerves and where each cranial nerve sits in the brain, the different lobes of the brain, different regions of the brain. Remember, all this content builds off of what you've learned in pathophysiology and biology. So make sure you go back and review your cranial nerves, where your cranial nerves are located in the different sections of the brain, of the different lobes of the brain, because all that will play into part of what symptoms you'll see in a patient that's had a stroke. Here are just a couple of diagrams of the blood flow. Remember the circle of Willis, which is specific to the brain. There's not another organ in the body that has a collateral or blood flow set up like the circle of Willis. And then it also shows your vertebral arteries and the portions of the brain that it supplies, and your carotid arteries. If you're not a very visual person, here it is in writing. The carotid arteries and the branches, what areas of the brain it supplies blood to, and then the vertebral arteries and its branches, what areas of the brain it supplies blood to. Again, here's just another visual, another diagram of the arteries of the brain and the circle of Willis and the arteries that make it up. As we mentioned earlier, and you saw in the video, they were talking about fast, and the T being time. Well, the reason time is such a big importance for stroke victims is because the brain itself requires a continuous blood supply of oxygen and glucose, and this is because the brain itself is not able to store oxygen or glucose. So it needs a continuous flow of blood to get the oxygen and glucose that it needs, because it's unable to store its own. When blood flow is interrupted in the brain, you can actually see a change in the metabolism of the brain cells in 30 seconds. And again, that's because the brain is unable to store oxygen and glucose. Therefore, you see an alteration in the metabolism very fast. Metabolism can stop in 2 minutes, and death can start occurring when the metabolism stops. And then you definitely have cell death at 5 minutes. Our body does have, and our brain does have, a protective mechanism that helps us to keep a continuous supply of blood to the brain, and that's this cerebral autoregulation. And what happens is, because we're not able to store our own nutrients, glucose and oxygen, in brain cells, and we need that continuous steady supply of blood to the brain, when you have changes in the blood pressure, the cerebral arteries can auto-regulate, and they can dilate and constrict to make sure that there's a continuous flow of blood to the brain. So they can change in diameter in response to blood pressures. You can also see the brain tissue set up collateral circulation, and this, you may see collateral circulation if there's been long periods of decreased blood flow. And then again, this is just a way to compensate for the decreased blood flow. The body will actually create a collateral circulation. We can have, like I said, we can have two types of strokes. We can have our ischemic strokes, which is from a clot, or we can have our hemorrhagic strokes. But one of the reasons we may have a decreased blood flow to the brain is because of atherosclerosis, and it's the hardening and the thickening of the arteries, and this can be a major cause of strokes. And with that, you see the plaque when it says the thickening of the arteries, and that's that plaque. But with atherosclerosis, the artery is not as pliable, and so therefore you don't have the dilating of the artery or the constricting of the artery to maintain blood flow. Because that artery's gotten hard and has gotten thick, it's not able to dilate or able to constrict to help with the blood flow to the head. Excuse me. Because of the plaque buildup, it can lead to thrombus formations and can contribute to the emboli. And we'll talk about emboli more with the hemorrhagic stroke. And this is just a diagram of where you might see the atherosclerosis or the plaque formation. And if you notice, it's typically at bifurcations of the arteries. And that's just because there's a little turbulence there in the artery where it bifurcates, and tends to be an area that you have a plaque buildup. In the video, the guy that was talking mentioned TIAs, or transient ischemic attacks, and they differ from strokes in the fact that TIAs leave no neurological dysfunction or impairment. So how do you know that there's any difference from a stroke to begin with when the patient initially has symptoms of a stroke or a TIA, you don't know that there's a difference. You don't know initially when the patient arrives to you if it is a TIA or if it's a stroke. They're treated exactly the same on the front end. How do we know if it is a TIA? Is on the back side if there's no loss of neurologic function. Basically, if they are normal after the TIA, all their symptoms resolve, then we know it was a TIA. But on the front side of it, you don't know if it's a TIA or a stroke. However, most TIAs do resolve in about 3 hours. And TIAs can be a warning sign for a stroke in the future. This video doesn't actually have any sound to it, but what it does show is some of the arteries leading to the brain, the blood flow of the brain, and then as it zooms in, we'll actually see a clot break off and the damage that it will cause in the brain. So that's just an illustration. So like I mentioned earlier, there are two types of strokes. There are the ischemic stroke and the hemorrhagic stroke, and this little video does differentiate between the two.
If my wife or one of my children needed
About 700,000 Americans suffer a stroke each year. That's one stroke every 45 seconds.
A stroke is a brain attack that occurs when there's interruption in the cerebral blood supply, resulting in the death of cells and some brain damage. When cells die during a stroke, skills controlled by that area of the brain are lost. The ability to move, feel, speak, or remember can be affected. How a stroke affects a person depends on what part of the brain is afflicted and how much damage results. Ischemic strokes account for about 83% of cases. They occur when clots form within the arteries that supply blood to the head. The blockage of blood results in insufficient oxygen getting to that part of the brain. Ischemic strokes can be divided into two subtypes, embolic and thrombotic. An embolic stroke occurs when a blood clot forms elsewhere in the body and a portion of the clot breaks off, traveling to the blood vessels of the brain. The clot continues its journey until it reaches vessels too small to let it pass. At this point, the clot gets lodged, blocking the blood vessel and causing an embolic stroke. Say the words Richard Nixon and embolic stroke is not what comes to mind. We're more likely to think of Vietnam and Watergate. But Nixon did have a deadly embolic stroke, which occurred when a clot in his heart traveled to his brain. The other type of ischemic stroke, a thrombotic stroke, can also be deadly. In this stroke, blood flow is halted due to a local blood clot, known as a thrombus, which develops in an artery supplying blood to the brain. Ischemic strokes are the most common type, but hemorrhagic strokes, which make up to 17% of cases, are often more dangerous. A hemorrhagic stroke occurs when a blood vessel ruptures and bleeds into the brain, compressing the brain tissue. Hemorrhagic strokes can be intracerebral, which is more common, or subarachnoid. In intracerebral hemorrhage, bleeding occurs in the vessels in the brain itself. High blood pressure is the main cause of this type of hemorrhage. If asked to recall Franklin Delano Roosevelt, you're not likely to think of intracerebral hemorrhages. But like Nixon, Roosevelt was a stroke sufferer. In fact, a brain hemorrhage led to his death in 1945. The other kind of bleed is a subarachnoid hemorrhage, which occurs when a ballooning of a weakened blood vessel or arterial aneurysm bursts. Blood then spills into the protective spinal fluid around the brain, causing it to be surrounded by this contaminated fluid. If the blood goes into the brain, or if the blood vessels spasm, it can cause a stroke. A stroke is a brain attack. No matter what type of stroke a patient has, it is important to seek medical assistance immediately, as lifetime disability or death can result.
Want to learn more? Check out other videos and sources on this site for more information.
Okay, and so as you mentioned earlier, we can have a ischemic stroke, which involves either a thrombotic stroke or an embolic stroke, or we can have a hemorrhagic stroke. And that's just a description of them. Remember that our thrombotic stroke is where we actually have narrowing and a clot form in the artery itself in the brain, whereas an embolic stroke is where the clot actually breaks loose from somewhere else in the body and is transported to the brain. So a thrombotic stroke forms in the arteries around the brain, whereas the embolic stroke comes from another part of the body. Usually the heart is where the embolic stroke normally comes from. And then we have our hemorrhagic stroke, and that's where we actually have a bust in the blood vessel or the artery. So our ischemic strokes are definitely our most common type of stroke, and they make up almost 80% of all strokes. And then we have, again, the thrombotic stroke, which occurs in the vessels of the brain, where the vessel has got plaque buildup and a blood clot forms, causing a narrowing of the vessel until it is occluded. And the thrombotic stroke is the most common type of stroke. And thrombotic strokes are closely associated with hypertension and diabetes, and these are often preceded by TIAs. And then we have our embolic stroke, and remember, this is where we actually have a clot that comes from another area of the body and occludes in the cerebral arteries. And it is the second most common type of stroke behind the thrombotic stroke. embolic stroke, the onset of the embolic stroke is usually sudden, and it may or may not be related to activity. And again, because doesn't form in the brain, and it's not because of plaque buildup over time kind of in the brain, they may not have the TIAs associated with them that you see with the thrombotic stroke. And then we have our hemorrhagic strokes, and they're not quite as common. They make up about that 15% of all strokes, and they're the hemorrhagic strokes, and of course they result from a bleed in the brain. Hemorrhagic strokes are usually more severe than your ischemic strokes. But blood can form in different places in the brain. You can have your subarachnoid space, which is the space outside of the brain, or you can have it in the ventricles of the brain. You can also have it in the tissue of the brain. The intercerebral tissue is the different places you can have hemorrhagic strokes. The intercerebral hemorrhage, like I just mentioned, is bleeding within the brain. Hypertension is the most common cause of this intercerebral hemorrhage. And this usually occurs during periods of activity. Symptoms are sudden in onset and usually progress very quickly over just minutes or hours from the onset of the bleed. Patients that have hemorrhagic strokes, especially the intercerebral hemorrhages, usually complain of having the worst headache of their life. Is usually the biggest complaint for these patients, and then they deteriorate pretty quickly. With hemorrhagic strokes, you can have different causes. You can have an aneurysm, and we'll talk about the different types of aneurysms here in just a minute. Or you can actually have an AV malformation, is what they call them. But over to the right is kind of a picture of what an AV malformation is. And basically what it is there's an artery that didn't branch out into capillaries and ended up just keeping a main branch into the venous system. So it didn't branch out and get real thin. So it's a bigger vessel, and those vessels can actually rupture because the venous side of that vessel is not made for the pressure that the arterial side has, and so the venous side of that larger vessel gets weak and actually ruptures. Give me just a second. Your intercerebral hemorrhages can, like I said, can be caused from an aneurysm, can be caused from hypertension, and can be caused from the arteriovenous malformation. Aneurysms can often be congenital. There is a genetic link, there is a family link with aneurysms. Again, like I said, with the hemorrhagic strokes, these patients usually complain of the worst headache of their life. They can have the neurological deficits, weakness on one side. They can have nausea and vomiting. They can have a decreased level of consciousness, and they may have high blood pressure. With these, they're bleeds, so they're going to deteriorate pretty fast, and you may see the nausea and vomiting and the decreased level of consciousness, and that's just surely because of the pressure on the brain tissue, because of all the blood in the tissue or around the tissue. You can have the subarachnoid hemorrhage, which is the bleeding into the cerebral spinal fluid in that space. It's between the arachnoid and the pia mater. So go back and review the layers of the brain. It's commonly caused by rupture of a cerebral aneurysm. And of course there's different types of aneurysms, and you can see them over there on the right. The majority of our aneurysms that occur are in the circle of Willis. And again, remember, these patients complain of the worst headache of their life. And if you look to the right, you see the three different types of aneurysm. And basically that's just where it is on the artery wall. The fish form basically is kind of a ballooning all the way around the artery wall. This is a lot of times what you'll see with the intercerebral bleeding, the fish form type aneurysm. You can have a berry aneurysm where at a bifurcation it kind of splits the bifurcation and is in the middle of that bifurcation. And then you can have the saccular aneurysm, and that's just on a artery, straight artery. You might have that ballooning out of one area of the artery wall. Subarachnoid hemorrhages, you can actually prevent these or prevent rebleeding of them, and that's by clipping the aneurysms. Coiling is also another procedure that's used, and I have video on both the coiling and the clipping of the aneurysms. We'll look at those in just a second. Okay, so what we might see from having a stroke. Well, the clinical manifestations affect body function. Usually motor, you'll have a patient complain of either a right-sided weakness or a left-sided weakness, numbness on one or the other side. They may lose the vision to see. Vision may become blurry. They may lose sensations, the ability to communicate, and they may have spatial deficits. You can also see intellectual function change with a stroke, depending on which hemisphere of the brain that you see the stroke in.
It was tragic. I didn't have a light.
Stroke is the biggest cause of disability in the United States. What exactly happens after a person suffers a stroke?
The specific disability caused by a stroke depends on both the extent of the brain damage and where in the brain the injury occurred. The brain is a complicated organ which is divided into several main parts. The right and left hemispheres, the cerebellum, which is located at the back of the brain, and the brainstem, which is located at the bottom of the brain. Each part is responsible for specific functions in the body. Let's look at how a stroke in each of the different areas of the brain might affect a survivor. A stroke in the right hemisphere of the brain often causes paralysis in the left side of the body. This is known as left hemiplegia. Right hemisphere stroke survivors may have difficulty with spatial and perceptual abilities, resulting in trouble picking things up, misjudging distances, difficulty dressing, and falling down. Survivors of right hemispheric strokes often have judgment difficulties. They often develop impulsive, dangerous habits, like driving a car when they do not have the spatial ability to do so. Right hemispheric stroke survivors may also experience left-sided neglect, causing them to ignore objects when they're left. For example, a person with this condition might not eat food on the left side of their plate. Conversely, a stroke in the left hemisphere of the brain can cause paralysis in the right side of the body, or right hemiplegia. Survivors of left hemispheric strokes may develop aphasia, a term used to describe difficulty with speaking or understanding language. Patients who have had a left hemispheric stroke often develop a slow, cautious style of behavior. They may need frequent instruction and biofeedback on the most basic of tasks. Both right and left hemispheric strokes can affect short-term memory, resulting in difficulty learning new information and impaired ability to retain it. A stroke that occurs in the cerebellum affects reflexes and balance. Cerebellar strokes can result in difficulty standing, nausea, dizziness, and even vomiting. The most physically devastating of strokes are those that occur in the brainstem. The brainstem is responsible for all involuntary functions of the body, like blood pressure, heartbeat, and breathing. Damage to this area may require life support. Brainstem strokes can also lead to problems with hearing, talking, and swallowing. No matter the type of stroke, some level of depression is almost always present in survivors. Strokes have a profound, life-altering effect on survivors. Most will need therapy and time to begin the healing process. If you have suffered a stroke, please be sure to remain under a doctor's care.
Want to learn more? Check out other videos and sources on this site for more information.
So just a reminder of the different areas of the brain. Go back and remind yourself of the different lobes of the brain and what's usually controlled in those lobes. So if you have a stroke in that lobe of the brain, you know what kind of clinical manifestations you would expect to see. This is just another diagram of what you might see with a right-sided brain damage or a left-sided brain damage or stroke, depending on the side. And they do vary. The person with right-sided damage tends to be impulsive and neglectful, whereas the person with left-sided brain damage tends to be very cautious. So, diagnostic studies. What would we do for these patients when they show up in the emergency room with a stroke? Well, first of all, we're on a time frame, and time frames start with when the onset of the stroke or the onset of the symptoms is kind of the time frame you have for whether or not you can use TPA as a treatment choice. But once they arrive in our ER, we kind of have a time frame as to when we want certain things done. One of them being a CAT scan. And the CAT scan we want as soon as possible with them arriving to the ER, usually within 25 minutes of their arrival, and hopefully for it to be read within about 45 minutes of their arrival to the ER. CAT scans are a great identifier to let us know in a hurry if this patient has had a ischemic stroke or if they've got a thrombolic stroke. Or a ischemic, I'm sorry. If they have got a ischemic stroke or a hemorrhagic stroke. We want to know if this is from a clot or if this is a bleed. And the reason being is treatment is different for those two types of stroke. With an ischemic stroke, we can see if they're a candidate for TPA, and maybe TPA is a possibility to see if we can bust the clot to decrease the lasting effects of the stroke. Where if it's a hemorrhagic stroke, of course, we can't give TPA. So a CAT scan's a fast way to be able to look at the brain and know if it's an ischemic stroke or a hemorrhagic stroke. It'll also let us know the size of the lesion and the location. Usually the CAT scan of the brain is done without contrast. And again, we want this study, we would ideally like to have it done within 25 minutes of arrival and read within 45. And if you look over to the right, that's just a diagram of what a stroke would look like on a CAT scan. Other things that we're going to do for these patients, we're also going to do maybe MRIs might be another diagnostic. We may do an MRA. Just depends specifically on maybe if the CAT scan didn't show us what we want to see, may depend on the physician, or if radiology was unclear, they may order other types of tests for these patients. We may also do ultrasounds of the carotid arteries to see if there's narrowing of the carotid arteries, and maybe this is a cause of the interruption of blood flow to the brain. So it's not uncommon, even if it was just a TIA and their symptoms resolve, for these patients to be admitted and then have further testing done. Usually ultrasounds of the carotid arteries is usually what they do if a patient is admitted with stroke-like symptoms. Let me step back a slide and let me explain a couple of these to you. The SPECT is a single photon emission computed tomography. Nuclear medicine uses it, uses gamma rays, and it provides a 3D image for the radiologist to read. And then the digital the digital subtraction angiography is done with fluoroscopy and usually in interventional radiology. When these patients come in, we're also going to check the heart. We're going to do a chest x-ray on them. We may do an EKG on them, check cardiac enzymes, because sometimes a stroke is secondary to a cardiac issue, especially like AFib. If they don't know that they're in AFib, that may be where our clot formed and went to the brain. So if they've got an ischemic stroke, we want to find out if they've got underlying cardiac issues, so maybe we can prevent future strokes. So not only will we check the brain and the arteries in the neck, we'll also check the heart. We may have these patients wear Holter monitors just to make sure that there's nothing going on cardiac-wise that could be the cause of the clots if they're having ischemic strokes. We also want to do blood counts on these patients. We want to do CBCs on them, platelets, protons, especially if they're on Coumadin or any of the blood thinners. We're going to check their clotting times, a PT, PTT, their INRs. We'll also check liver function, and we'll check renal and kidney functions. One of the reasons we check liver functions is because that's where platelets are produced, and so we need to know if the liver's functioning okay and if we've got adequate platelet production. And so for these patients, we want to prevent strokes if possible. So going back to the modifiable risk factors, a lot of this is education. A lot of this is maybe they weren't aware of things that they can do to change the risk factors for having a stroke. Of course, now there's some of them, again, are non-modifiable risk factors that we can't change, but then there are others that we can. Diet, their exercise, cholesterol, if they have high blood pressure, making sure that they're compliant with their high blood pressure medicine, and if they're not, find out why. A lot of times you'll find that people are non-compliant, one, either because they don't know, or two, because there's a financial strain and they're not able to be compliant due to the cost of meds. So if you'll find out why a patient's non-compliant instead of just assuming, oh, they're non-compliant and writing them off, a lot of times we can get social services involved, and there's programs out there that can help us pay for their medicines, or even their physician can change their medicine so that they're on a much cheaper prescription. I know a lot of our pharmacies and have what they call their $4 list, and there's tons of meds out there that are on their $4 list. Maybe would it be probably the preference medication? It might not be, but if it would do the job and it's something that they would be compliant on because they would take it, we'd much rather swap their medicines so that they're compliant than putting them on a more expensive medicine and then them not taking it because they can't afford it. So finding out why they may be non-compliant, but again, we want to try to prevent strokes and maybe preventing a second stroke. So a lot of education goes into taking care of a stroke patient. We want to make sure that we have them on specific drugs like your antiplatelets if that's what they need to be on. A lot of these patients are on aspirins a day. Even if they don't have a history of stroke, if they've got cardiac issues, you'll see them on 81 milligrams of aspirin a day. If they're having TIAs and we do the ultrasounds of the carotid arteries and find that they've got plaque buildup in their carotid arteries, we can do carotid endarterectomies and remove that plaque to decrease the risk for strokes. And this video shows a carotid endarterectomy. We can also stent arteries that are occluded with plaque. If they're in the brain, kind of like we stent arteries around the heart, we can now stent arteries in the brain. And we can also do bypass of arteries around the brain. So there's many surgical interventions that can occur to prevent strokes. And with the extra cranial intercranial bypass, what they do is basically connect a branch of the external carotid artery to a branch of the internal carotid artery, and this is with a venous graft, and this is used with severe stenosis or occlusions of the inner cranial arteries. Let me show you this video of this carotid endarterectomy.
This is the main artery to the brain. Smoking makes fatty deposits stick to its walls. If they stop blood flow to your brain, or if a piece breaks off, it can cause a stroke that can kill, blind, or paralyze. Not all smokers have strokes, but all smokers do have fatty deposits in their arteries that can cause a stroke at any time.
And that happened to be related to a smoking commercial, but it showed how that plaque can just build up on the inside of the artery, and they just remove it kind of like a piece of tissue. It's amazing how it is together like that. But anyway, that's the carotid endarterectomy, and that's the removal of the plaque on the carotid arteries of the neck. Again, this is just the diagram version of kind of what you saw earlier. And I mentioned stenting. You can actually, like we stent the heart, you can stent arteries around the brain, and this is just showing you how they put the transducer through the plaque or the narrowing and blow a balloon up and then put the metal stent in. So for the acute care phase, and that's immediately when the patient arrives, collaborative care, of course, is preserving life. These patients can deteriorate, and they can deteriorate very severely, especially if we start talking about the brain stem. And remember, that's where we have our life functions, breathing, heart beating. And if we start having enough brain swelling, or we have enough bleeding in the brain, or we have enough ischemic changes in the brain that we have severe brain death, and then brain swelling, you can also start worrying about preserving life. These patients can die from strokes. We also want to prevent further brain damage. So if we can stop the bleed, or if we can give them TPA to bust a clot to prevent further damage, of course that's what we want to do. And then we want to reduce the disability. Our goal for these patients long term, of course, is to return them to an optimal functioning level. And remember, that's different from normal or what they were prior to coming in. We just want to get them back to their highest possible level of function, because we realize with strokes, a lot of times they will never return to what they were prior to the stroke. So when we're assessing these patients' assessment findings that we might find on a stroke patient, well, one would be an altered level of consciousness. They may be weak or have numbness or paralysis on one side of the body. They may have speech or visual disturbances. They may be complaining of the worst headache of their life. And in more severe cases, you'll start seeing changes in heart rate and respiratory distress. They'll also, you may see unequal pupils, or what they call a blown pupil, and that's due to intracranial pressure. And we'll talk more about intracranial pressure later on. You may find that they have hypertension. These patients may have had hypertension for years and not known that they were hypertensive until they had a stroke. Facial drooping, and with facial drooping, it'll be on the affected side. May have difficulty swallowing. They may have bladder or bowel incontinence, again, nausea or vomiting, or even problems with balance or vertigo. So what we'll do for these patients initially, of course, it's always in taking care of an emergency, it's always your ABCs. But airway, breathing, and circulation, of course, we want to make sure that the patient can maintain an airway and is breathing, and then we'll go from there. We want to remove dentures. If they have dentures in place, we want to get rid of remove the dentures. We want to call our stroke team so that we can initiate stroke orders and protocols. Again, these are on time frames. Federal government is looking at time frames for strokes. And remember, we can only administer TPA within the first 3 hours of the onset of symptoms. So we want to know as soon as possible if this is an ischemic stroke, and if it is an ischemic stroke and we've fallen within our 3-hour window, they may be a candidate for TPA. So we are on a time frame. We want to administer oxygen to them. Remember, our damage is because the brain has a lack of oxygen and nutrients to it. So we want to provide oxygen so that every bit of their hemoglobin has oxygen all over it. So if they have a collateral circulation, maybe they're getting a little bit of oxygen to the brain tissue that might be damaged. We also need IV access on these patients. Remember, they can deteriorate quickly, but we do need IV access on them. And we want to monitor their blood pressure. Remember, a lot of these strokes occur because of hypertension, so monitoring the pressure is very important. We want to get rid of all their clothing. One reason being because, one, we're going to take them to CAT scan, and they can't have metal on with CAT scan or when they're scanning. And two, because we want to be able to do a thorough assessment on them. We want to get baseline labs. We want to get the CBC and the CMP. We're going to check PT and PTTs and INRs, and that's to get baselines. We may even check, again, cardiac enzymes to see if they've had a heart attack, or see if there's something cardiac issue-wise going on. We want to keep their head midline with their body, and we want to keep the head of the bed about 30 degrees. That's if they're showing no signs of shock. But now, if they are showing signs of shock, then of course we may have to lower the head of the bed. Because there's damage to the brain, these patients have an increased risk for seizures and may be put on seizure precautions. You'll even a lot of times see these patients put on seizure medications, even if they have not had a seizure, just to prevent a seizure from occurring. They'll be put on antiplatelet drugs, or maybe even thrombolytics such as TPA. Retavase. All of those are your clot-busting drugs, your thrombolytic agents. If they're hypertensive, we'll treat their blood pressure. If we're showing that there are electrolyte imbalances, of course we're going to correct those. Make sure that they're adequately hydrated. And as we continue to take care of these patients, even after this acute phase and on into their hospital stay, again, we're still monitoring their level of consciousness. We're still checking their motor and sensory function. We're still checking their pupils, their oxygen saturation, their cardiac rhythms, because remember, there's a lot of times there's a cardiac underlying issue with these patients. And the reason we implement seizure precautions and sometimes put them on seizure medications to prevent seizures is because approximately 5 to 7% of patients who experience a stroke will have a seizure within 24 hours of the stroke. Some of the drugs that we may use, drug therapy, we may use calcium channel blockers, and that's to reduce cerebral vasospasms. You may see, especially if they're a bleed, you may see mannitol used, and that's to decrease the cerebral swelling with edema. It'll decrease the cerebral edema. You may see diuretics like Lasix used. Again, you may see them put on anticonvulsant drugs to prevent seizures. Depending on what portions of the brain are affected, you may see them put on antipyretics like Tylenol or acetaminophen, and that's because depending on the portion of the brain, they may have trouble controlling body temperature. You may see spikes in body temperature. They're on anticoagulant drugs such as aspirin, and maybe even thrombolytic drugs, depending on if it's an ischemic stroke and we've fallen within our 3-hour time frame. You may see TPA or Retavase or any of those used on these patients. And again, this is just telling you that TPA is used to reestablish blood flow to a blocked artery to prevent cell death in the patients. And this is with ischemic strokes. It is contraindicated in hemorrhagic strokes. And remember, they must be within 3 hours of the onset of symptoms, not within 3 hours of their arrival time to the ER or to the hospital. If there is a surgical intervention needed, depending on the type of stroke, that may be done immediately. You may have an aneurysm clipping. You may have an aneurysm that has caused a hematoma, and the hematoma is evacuated. You may see them go in and evacuate cerebral hematomas, and again, that just depends on the type of stroke that they have and where the stroke occurs. And this is just an example of what clipping the aneurysm might look like versus the fissuriform aneurysm, where they may just wrap it. And this, I'm going to show you a clipping, and then I think the other one is actually cooling of an aneurysm. what they're doing was just checking blood flow, making sure there wasn't still blood flow to the aneurysm. Showed a brief coiling. I do have a little more in-depth video on the coiling. But I just showed you just a diagram of the aneurysm clipping.
Coil delivery and detachment. A guide wire is introduced into the artery. The guide wire enters the aneurysm. Next, we see a shaped Boston Scientific Target 2-tip microcatheter delivered into the aneurysm over the guide wire. The guide wire is retracted and the microcatheter is optimally positioned for deployment of the first Matrix 3D coil. The first Matrix 3D shaped coil is placed into the aneurysm through the microcatheter. The Matrix 3D coil deploys into a complex basket as the alternating small and large omega-shaped loops are delivered into the aneurysm. Next, we see the detachment zone dissolve as a result of the patented, motion-free, electrolytic detachment process. Please note that no mechanical movement is required to detach the matrix coils. The pusher is then retracted from the microcatheter. The matrix detachable coil deployment continues in the aneurysm. Endothelial coverage of the aneurysm neck. After stasis and subsequent thrombus formation occurs in the aneurysm, endothelial cells originating from the parent artery migrate over the surface of the thrombus, thereby covering the aneurysm neck.
And that's just a little more detail on how the coiling takes place. And there's the diagram introducing the femoral artery. And then on the ischemic strokes, sometimes you can have embolus or a clot removed, and it's done mechanically. And this is just a diagram of that. Basically, it's kind of a balloon put above the clot, and then a coil that kind of wraps in the clot, kind of suctions and removes the clot, and then they make sure that all of the pieces that might have got broke loose are out of that area before they deflate the balloon. So in rehabilitation, after the stroke has stabilized and it's been 12 to 24 hours and we've seen the progression of damage and we know the extent of the damage, now we want to start trying to rehabilitate these patients. And our care shifts from like preserving life to lessening the disability of the stroke and returning this patient to the optimal function. And usually, again, that's in about 24 hours after we know the full extent of the stroke and we have preserved life in that first 24 hours. Long-term patients are transferred to rehabilitation units, to outpatient therapies, home care-based rehabilitation. And again, a lot of this is unfortunately based off reimbursement as to what their insurance will cover as far as rehabilitation. When we are taking a history on the patient, and if the patient is stable and able to, we want to obtain this history from the patient, but we want to know the description of the current events. We want to know if they've had previous symptoms, what medications they're on currently, if there's risk factors, history, a family history of a stroke or cardiovascular disease. We want to try to get as much of the puzzle answered as possible by the patient. And again, that's assuming that the patient is stable and able to answer these questions. If not, this information will have to come from family or anybody that might be with the patient. We're going to do a comprehensive neurological assessment. We're going to check their level of consciousness. We're going to check their motor abilities. We're going to check cranial nerve function. So remember, go back and look at your cranial nerves. We're going to do tendon reflexes, check sensation. All of these is part of that detailed neurologic assessment. And of course, with the management of the patient, we're going to basically check all of their systems. We're going to make sure that we've got physical therapy or occupational therapy in for musculoskeletal, and that we don't have skin breakdown because they're no longer able to move that extremity. If they're incontinent, we're going to keep an eye on their GU and GI tracts. We want to make sure that these patients are adequately nourished. We're going to check their mental status. We're going to keep an eye on their sensory and perception. And remember, a lot of times these patients have trouble with coping and are depressed, so we may need antidepressants for these patients. Unfortunately, some patients lose posture and are unable to keep themselves upright in a chair, and that's common after strokes. And remember, with patients, they can lose visual field on one side of their body. Maybe they may not see what's on the left side of their body. And so if you find a patient that's only eaten the food on one side of their body, or they tend to look to their right but won't look to their left, or don't acknowledge people that are standing on their left, that's very common with strokes. When we rehabilitate these patients, we may have to teach them new ways to eat and drink and devices that they can use. They may have been right-handed, and now we're having to teach them how to cut with their left hand or use a left-handed fork. And you think about it, it's hard to cut a piece of meat if you've only got one hand and you don't have the other one to stabilize it. But there's many different adaptive devices and assistive devices that are out there to help these patients, and a lot of times it's just seeing what devices they need and getting those devices available for them. And a lot of that comes with rehab, and then of course with physical limitations. We want to make sure that they have rehabbed to an optimal function. We want to see if they need home care, or if they're able to even go back into the home. And this is all follow-up, again, after that acute phase, and we've moved into the long-term, to getting them back to their optimal function. And that is it for TIAs and strokes.